Welcome to AETCM, the Emergency Medicine channel. As a part of EM Rapid 2024, today we are going to discuss about nutrition in ICU. So, malnutrition in ICU can cause increased morbidity and mortality in critically ill patients. So, malnourished patients can have weakness in respiratory muscle weakness, lowered ventilatory capacity and reduced GI tolerance. So, this leads to requirement of prolonged mechanical ventilation, difficulty in weaning, gastroesophageal reflux, presence of aspiration pneumonia and chances of infection and multi-organ failure. So, energy and nutrients not only preserve body's figure or structure but also represent a promising therapeutic elements, and it is having profound metabolic, inflammatory, endocrinologic and immunological alterations in critically ill patients. So, what is a malnourished patient? So, malnourished patient is a patient who is having a BMI less than 18.5 kg per meter square, or a patient with a history of weight loss of more than 5% within last 1 month, approximately 2.5 kg, or history of weight loss more than 10% within last 6 months, approximately more than 4.5 kg, or a BMI less than 20 kg per meter square and unintentional weight loss of more than 5% in the last few months. These are based on the weight. Otherwise, when we look at the patient, we will be able to see the patient will be malnourished based on the loss of muscle mass and fat loss, then based on the patient's oral health and all. Along with that, some lab parameters like albumin and phosphorus also, if it is low, then that means patient is malnourished. So, this means that patient is already malnourished. So, when this patient gets admitted to critical care unit, we will have to manage patient's malnourishment, existing malnourishment, and also give essential nutrients to the patient. So, pathophysiology of malnutrition in critically ill patients. So, in stress, during stress there is a stress catabolism. So, depending on that stress catabolism, the degree of inflammation will increase and the disease severity will increase, and along with that, if there is an inadequate nutrition intake, that will worsen the patient condition. So, in acute critical illness stage, patient will be more of in a stress catabolism phase. So, that time patient will require more of carbohydrates, whereas as the patient recovers, patient will be in an anabolic state more than a catabolic state. That time patient mostly requires proteins. So, proteins are to replenish the nutrient stores and also the muscle. And in ICU, while the patient is being admitted, as I told before, we need to treat the pre-existing malnutrition and minimize muscle wasting. So, feeds can be started, nutrition can be provided by oral nutrition if the patient is able to take orally, or enteral routes directly to the stomach through a Ryle's tube. So, gastric route or through peg feeding or jejunal approach, or if nothing is possible or if the patient cannot be given through an enteral or oral route, then parenteral nutrition. Parenteral nutrition, mostly we will keep a dedicated central line, mostly a central line, or now we have the peripheral nutritions also, parenteral nutritions. So, this is actually a Nutric score. Nutric score is determined to see how much is the patient's nutrition, and depending nutrition along with the age, patient's general condition and all, we will give a score, and as the score increases, along with that the patient is having reduced oral intake, then or feeding, so patient's disease condition may worsen. So, for calculating that, we will be considering the age, the Apache score, then the SOFA score, presence of the comorbidities, days from hospital to ICU admission, and interleukin value will be considered, and we have some points based on that. And if the score is high, that means the patient is having a worse clinical outcome and the mortality and chance of ventilation is high. So these patients should be treated with aggressive nutrition therapy and should not go into malnourishment. So this score should be done when a patient presents to an ICU, so that we can plan and treat accordingly. And when we are planning on a patient's diet, we have different type of diet. So one is isocaloric diet, is an energy administration of the defined target will be given, or otherwise some patients will be giving hypocaloric diet or underfeeding, that is usually given in very critical ill stage. In initial few days we might plan on a hypocaloric diet, that means giving an energy below 70% of the defined target for the patient. Or or other terms are overfeeding. Overfeeding means giving energy more than 110 above the target. Or low protein diet. Low protein diet is another type of diet in which there is a protein administration below 0.5 gram per kg per day. And there is other diets called as tropic diets and all, which means that we are giving very minimal diet to the patient, even less than the hypocaloric diet, that is actually to preserve the gastric motility and the gastric villi. So this is the general approach of nutrition in ICU patients. So in the acute phase in the ICU, in the first 4 days, so initially first day we will be starting low feeds, like 25% will be starting, and based on patient's tolerance we will be increasing the requirement. First we will be giving only 25% of the target, then 50, 75, like that we will be increasing. And that post acute phase, around 5th day and all, we will be giving patients calories according to patient's weight. So based on the weight, if you are calculating, we will be mostly giving 100% of the feed, but whereas if we are using some predictive equations and all, we will be using the hypocaloric diet. So 70% of the predictive equation diet will be given, that is in case of calories. And when we are starting with proteins, minimum protein will be given initially, so 1.3 gram per kg per day. And in the post ICU phase we will be increasing, so we will be increasing the patient's requirement. So 125% of the predictive will be given, or we will be increasing the calories to 30 kilocalorie per kg per day, and we will be increasing the proteins to 1.5 to 2 grams of protein per kg per day. And after that post ICU phase and after discharge, we will be increasing the feeds to 150% of the predictive one, and the calories also will be increasing to 35 kilocalories per kg per day, and also the protein will be increased to 2 to 2.5 gram per grams of proteins per kg per day. So that is how we increase the nutrient supply to the patient. So in a hospital or in an ICU, what is the usual calories which we give? So first we will discuss about the protein. So protein range requirement is from 1.2 to 2.2 gram per kg per day should be provided, and based on the patient's clinical conditions and disease condition, this will vary. So in usual patients the target is to give 1.2 to 2 gram per kg per day, but not from the first day onwards. As we told, from the first day onwards we will be starting as 25%, 50%, slowly only we will be increasing. So this is the usual target. And calories we will be giving 25 to 30 kilocalories per kg per body weight per day. And in most critically ill patients, as we told, we will be usually giving a low calorie diet initially, that is 18 kilocalorie per kg per day. And in patients other than proteins and calories, we will give intravenous lipid, especially in case of parenteral nutrition, that we will be usually giving 0.4 to 0.75 gram per kg per day, and it should not exceed 1.5 gram per kg per day. and some micronutrients also are required for the patient, and it will be usually included with the enteral diet and should be also provided with the parenteral nutrition. And patient also requires water. So water we require 1 ml per kilocalories for the patient. This is by considering the insensible loss. Insensible loss is the respiratory loss or the water loss which we cannot measure through urine output or stool output, or whatever loss we won't be able to sense, that is called as insensible loss. So along with the water we will have to give the additional insensible loss fluid also. And fluid restriction should be considered in case of any hepatic failure, cardiac failure, renal failure, any CNS injuries, and also in case of any electrolyte abnormalities like SADH and all, we will have to consider fluid restriction. So we were mentioning about the micronutrients. So micronutrients, some of them are thiamine. Thiamine is important for the energy and carbohydrate metabolism, and in enteral nutrition we usually give 1.5 to 3 mg per day, and in parenteral nutrition we will be giving more than or equal to 2.5 mg per kg per day. And vitamin C. Vitamin C is a very good antioxidant, a neurotransmitter, and also it will help in healing, especially in burnt patients and all. So enteral nutrition, the dose is more than 100 mg per kg per day, and in case of parenteral we will be giving 100 to 200 mg per day. Then vitamin D. Vitamin D helps in mineralization of the bone, immune functions and all, and it will be helpful in critically ill patients. So enteral nutrition we will be giving more than 1000 international units per day, and parenteral more than or equal to 200 international units per day. And selenium also helps in decrease inflammation, and also it is having antioxidant and healing properties. So it is in enteral nutrition 50 to 150 microgram per day, and parenteral nutrition 60 to 100 microgram per day. So nutrient dosing. So as I told, the nutrition dosing can be calculated by using different methods. We can use predictive formulas to calculate, or we can plan based on the patient's weight. So if a patient is, so we were mentioning like we will be giving 25 to 30 kilocalories per kg per day, or protein we will be giving 1.2 to 2 grams per kg per day. So what is that kg, that weight? So in usually underweight patients and all, we use the patient's current weight for dosing, whereas if the patient is normal BMI, then also we will be using the current weight as for dosing the feed, whereas in obese patients we can use the ideal body weight. So ideal body weight for females and males should be calculated, and then that should be given. So usually the dosing weight will be ideal body weight plus 0.25. And how to start feed? So how to start feed, as we told, we will be planning based on a weight based equation. So if we are planning on a weight based equation, we have mentioned the dose. So if it is like 25 to 30 kilocalories per kg per day is the requirement, we can start like that. And if the predictive equation, if we are using predictive equations, we usually start with the hypocaloric nutrition that we have told when we have started that table. So we will be initially starting in the hypocaloric nutrition, and the first week of in the ICU we will be starting as low dose. So initially we can start as, if we are giving through a Riles tube or orally and all, we can give 25 ml each initially with a gap of like 2 to 4 hours we can give, and based on patient tolerance we will be slowly increasing. And after the third day and all, so the calorie delivery will be increased up to 80 to 100%. That means we will be from hypocaloric diet, we will be going into isocaloric diet. And so that is isocaloric nutrition will be progressively implemented after early phase of the acute illness. And in case of obese patient, based calculation can be used, or we can use based on the actual body weight. If you are using actual body weight, we can give 11 to 14 kilocalories of the actual body weight per day for patients with a BMI ranging from 30 to 50, or we can use 22 to 25 kilocalories per kg of ideal body weight for patients with BMI more than 50. So we have already mentioned that we will be either using the ideal body weight or we can use the actual body weight. And one thing we should note is that if patient is obese and if we are restricting the nutrition for that patient, some elements, nutrition itself will be depleted, especially patient's micronutrients will come down. So we shouldn't avoid giving feeds to an obese patient. So electrolytes and nutrients, especially micronutrients, are necessary for all patients, and obese patients should get adequate feeds as required for them. And if the patient is having vitamin D deficiency, in critically ill patients, if it is very low vitamin D level, especially less than 12.5 nanogram per ml and all, then we can give 5 lakh international units of D3 single dose can be administered within a week after admission. So vitamin D should also be given in critically ill patients. And if the patient, we are having a patient with hepatic failure, in such patients we will have to increase the calorie requirement to 35 to 40 kilocalories per kg per body weight per day, and protein is 1.2 to 1.5 gram per kg per body weight per day. And if the patient is having respiratory failure, usually respiratory failure patients are considered to be given, we will consider to give a low carbohydrate diet, considering that carbohydrates will increase the carbon dioxide level. Along with that, we will plan for a high fat and low carbohydrate diet, but it is not recommended now in case of acute respiratory failure. So calorie dense enteric feeds can be given to them, but small frequent diet should be given to increase the compliance. And in case of acute kidney injury patients, we should increase the protein requirement for them. So they can be given proteins up to 2.5 gram per kg per day. And in case of obese patients, as we told, we should evaluate for micronutrient deficiencies and calcium, thiamine, B12 and fat soluble vitamins, folate and trace elements like iron, selenium, zinc, copper and also should be considered. Usually routine dose use of probiotics are not recommended in ICU. And in case of burns patients, they also require a high protein diet. So for them also enteral nutrition should be started within 12 to 24 hours, and protein requirement is 2 to 2.5 gram per kg per day, and micronutrients are also mandatory, especially A, C and E, and vitamin C, selenium and zinc will help for healing of burns. So when should nutrition be initiated in critically ill patients? So as early as possible, within the first 24 to 48 hours it should be started if there is no significant contraindications. And what is the route which we prefer? So if the patient is able to take orally, prefer the oral route itself. If that is not possible, we can plan the enteral route through Ryle's tube or something if the patient is ventilated and all. That also within 48 hours it should be started. If in case of any contraindications to oral or enteral feed, or if you are not able to feed the patient for the next 3 to 7 days, then we will have to start parenteral nutrition. So tube feeding can be considered along with the oral feeding if the patient is not taking adequate diet, and if the patient is not taking 50 to 60% of the required one, then we can consider giving enteral feedings. And usually continuous formula feed is preferred rather than giving bolus feeding. Usually adults like us and children, usually humans eat as a bolus feed, but in critically ill patients we will have to give them continuous feed rather than giving bolus feeds, because they won't be able to tolerate that. So when should we consider post pyloric enteral nutrition like jejunal or peg feeding and all? So usually the gastric access is the standard approach, but post pyloric feeding is considered if the patient is not tolerating the gastric feed, or if the patient is having severe gastroparesis, and also if there is a problem in that, or if the gastric feeding intolerance is not solved with any prokinetic agent, and if at all there is a risk of aspiration, then we will consider the jejunal approach. And how will we monitor the enteral nutrition we are giving to the patient? So if we are giving a feed to the patient and if the patient is vomiting, that is not a contraindication to stop feed. We can restart the feed by restarting as if we are giving it as a 100 ml per hour, we can reduce it to 75 ml per hour. So restart the feed at a 25 cc per hour less than the previous rate, and inappropriate cessation of feeding because of vomiting should be avoided. And if at all the patient can for NPO for some diagnostic test or procedures, that should be minimized. NPO time should be minimized. So immediately after procedure, feed should be restarted. And gastric, we will be in between, we will be checking for the what all things we will be after giving feeds, we will have a tendency to aspirate and see any residual feed is coming back or not. So that also should be monitored only 6 to 8 hourly. Even after giving feed, immediately don't aspirate and see. So stomach will take at least 2 to 5 hours to empty the gastric content. So we will be considering suctioning that and looking for the gastric reserve volume only after 6 to 8 hours. And if at all there is a gastric aspirate of more than 500 ml only, we will be considering that as intolerance. So high GRV, vomiting or regurgitation, so maximum more than 500 ml at least once, and we will be monitoring that only, as we told, only 6 to 8 hourly. And if the patient is having diarrhea, that means more than 3 episodes of loose stools, any abdomen distension, GI bleeding, or if there is any increased intra-abdominal pressure. So usually intra-abdominal pressure is from 5 to 7. So if the intra-abdominal pressure is increasing because of the gastroparesis to increasing more than 12, or if the patient goes into intra-abdominal compartment syndrome with intra-abdominal pressure more than 20, and if there is any so what will happen is, because of the increased intra-abdominal pressure, the perfusion to the abdominal organs will be affected. In such cases only we will be considering these patients as having intolerance to the gastric feed, and these patients should be considered having some gastrointestinal dysfunction. And if this patients, sometimes in these patients we can try prokinetic agents if the patient is able to tolerate the feed based on prokinetic agents or not. So either we can give intravenous erythromycin 250 to 500 TID, or alternatively we can give metoclopramide along with erythromycin. So metoclopramide, if you are giving 10 mg BD or TID can be given. So when should we implement parenteral nutrition? So as we told, parenteral nutrition should be considered if we are not able to give oral or enteral feeding within the 3 to 7 days, and a combination of enteral with parenteral nutrition is not usually recommended. And parenteral nutrition should be given through a dedicated line. So if there is a central line for the patient, we should use the longest port line of it, and it should be a dedicated line. We shouldn't be giving the parallel nutrition and the IV medication everything through that single line. So if it is a three-way central line, one line if it is dedicated to the feed, then it that means that parallel nutrition, then only that should be going. If along with that, if any other medicines or anything is going through the same line, there is high chance of venous thrombosis, bloodstream infection, especially fungal infection. And before considering giving parallel nutrition, we should look for any contraindication whether it is there or not, because it is a highly concentrated. So there can be hyperglycemia, hyperosmolarity, serum electrolyte abnormalities, and also these are some contraindications, and if anything is there, that should be corrected and then only should be planned on giving parallel nutrition. So what are the causes and risk factors of diarrhea in case of nutrition in ICU? So if the patient is having fever, hypothermia, any presence of infection, or if the patient is having hypoalbuminemia and malnutrition, sepsis, multi-organ dysfunction, then open feed container or previous total parallel nutrition patients, we are at the risk of having diarrhea. So these patients are at risk, and other causes which can induce diarrhea are giving overdose of hyperosmotic agents or drugs like sorbitol, then broad spectrum antibiotic, pseudomembranous colitis, then intestinal infections or irritable bowel syndromes, or intestinal graft versus host disease after stem cell transplantation. Now, in which all patients should we give enteral nutrition as early as possible? So, these patients who are receiving ECMO, traumatic brain injury, any patients with stroke, spinal cord injury, pancreatitis, GA patients immediately after surgery, GA surgery patients after especially not the gut surgeries, other solid organ surgeries, then in patients with abdominal trauma when the continuity of GI tract is confirmed or restored, and in patients receiving any neuromuscular blocking agents, and the patients with the presence of bowel sound, and after ruling out bowel ischemia and obstruction, we can immediately start the feed, and even in patients with diarrhea, early enteral nutrition should be given. So when should enteral nutrition be delayed in ICU patients? So in patients who are on 2 or more vasopressor supports in high doses, there is a chance of gut ischemia because these vasopressors are vasoconstrictors. So they will be usually giving more blood to the organs like brain, heart and all. So if the mean arterial pressure is very low, the gut perfusion will be very less. So there is a chance of gut ischemia. So in such patients, enteral nutrition enteral nutrition or usually they will be in ventilator, and we will be usually giving enteral nutrition. So in that case, enteral nutrition can sometimes cause gut ischemia. So in that patients, we can consider delaying the nutrition. And if the patients who are having active upper GI bleed, so when bleeding has stopped, and if there is any no sign, if the signs of bleeding everything is stopped, then we can start nutrition again. So in case of presence of active GI bleed, we should delay the enteral nutrition. If the patient's gastric aspirate is more than 500 ml after checking 6 hourly, then also we can delay the enteral nutrition. And if the patient is having any features of overt bowel ischemia or any features of abdominal compartment syndrome, after giving adequate prokinetic agent and also after relieving that only, we will have to continue feeds. So when should we give low dose enteral nutrition? That is considered in case of patients who is receiving hypothermia. So we don't want the patient's basal metabolic rate to increase, and we will be considering increasing the dose of feeds when we are rewarming the patient. Then low dose enteral nutrition is given in case of intra-abdominal compartments, intra-abdominal hypertension without features of compartment syndrome. and in patients with acute liver failure. So what all are the laboratory parameters which we usually monitor in case of giving nutrition to ICU? So in ICU we will be usually correcting the malnutrition and also giving the required feed for the patient. So if you are giving too much of nutrition, there is high chance of hyperglycemia. So in the ICU our cutoff glucose ranges from 140 to 180, and if the patient is going to hyperglycemia, insulin shall be started, and monitor for electrolytes, especially potassium, magnesium and phosphorus. Why? Because the patients with malnutrition are having a high chance for going for refeeding syndrome after starting feeds. So we will be discussing that later. So such patients we should measure potassium, magnesium and phosphorus every day for the first week. And in patients especially phosphate is the one. So in patients with refeeding, for hypophosphatemia is of high risk, so we will have to measure electrolytes and we will have to supplement if the patient is going into hypophosphatemia. So we will discuss about refeeding syndrome. So refeeding syndrome usually happens in patients who were previously malnourished, like patients who is having chronic illness, like any patients with malignancies, HIV, DK, like that. So when the patient gets lot of feeds, this patient will immediately go into an anabolic reaction. Then some complications will happen. So it is actually a life-threatening condition, and this patient, what is happening is when the patient gets lot of feed, the body will go into anabolic state, and what will happen is all the electrolytes from the extravascular space will go into the intravascular, from the extracellular fluid will go into the intracellular region. So there will be a shift of electrolytes from the extracellular area to the intracellular area. So there will be reduction in the electrolytes like phosphorus, potassium, magnesium, everything will be coming down. So patient will have serious complications like arrhythmia and all. So it usually happens within the first 3 days of starting nutrient support, and sometimes the patient will have symptoms like full spectrum symptoms because of refeeding syndrome. Sometimes mild form, sometimes they might not have any symptoms, and suddenly they can go into sudden cardiac death because of arrhythmias. So these are seen mostly in patients who were already in anorexia nervosa, chronic alcoholic patients, oncology patients, post-operative patients who were not receiving feed for many days, then elderly patients with lot of comorbidities, uncontrolled sugar patients, then prolonged fasting patients, low energy diet, patients who is taking low energy diet, marasmic patient, and a morbid obese patient with profound weight loss, then patients having some malabsorption problem, then patient who is taking long term antacids and diuretics. So what happens is, as I told, if the patient's body in malnutrition will be mostly in catabolic state, so this patient's glucagon will be very high and insulin will be less. So when we start feed, what will be happening is there will be glycogenolysis, increased protein catabolism, gluconeogenesis, vitamin and mineral nutrition levels will be low. These patients before giving feed itself will be in a catabolic phase. So what will happen is insulin will be low and glucagon will be high. So gluconeogenesis will be increased in the body, glycogenolysis will be high in the body, and protein catabolism will be high in the fasting state. This is the fasting state or in the malnourished phase. And the vitamins and the micronutrient levels will be very much less. As we start feeding, what will happen in the patients? Carbohydrate will be used as a main energy source. So insulin will be produced more in the body. As a result, body will go into an anabolic phase. So increase in protein synthesis will be there, more of glucose uptake, then thiamine use will increase, and as I told, intracellular shift from the extracellular fluid, the phosphorus, magnesium, potassium will all go into the intracellular space. So there will be extracellular deficiency of phosphorus, magnesium and potassium, and also there will be sodium and water retention also. So what will happen, patient will go into edema. So patient might have pulmonary edema features, breathlessness and all. So these are the main features. So ultimately we can see the patient having hypokalemia, hypophosphatemia, hypomagnesemia and sodium and water retention. So what all are the symptoms in refeeding syndrome? So cardiovascular abnormalities like tachyarrhythmias, tachycardia, hypotension, because of the fluid and water retention, patients can go into congestive heart failures and edema. Then GI complications, GI symptoms like vomiting, constipation, abdominal pain will be there. Then muscle weakness, myalgia can be there. Then respiratory muscle weakness, especially because of hypokalemia and hypomagnesemia, patient can have respiratory insufficiencies, respiratory failure and ventilator dependency, and patient will have muscle weakness, respiratory muscle weakness. Then neurological complaints like anorexia, paresthesia, tremor, Wernicke's encephalopathy, then ataxia, tetany, delirium, seizures and coma. Then metabolic abnormalities, patients can have hyperglycemia because of the feeds. Then because of the hypokalemia, patient can go into metabolic alkalosis, and patient can go into metabolic acidosis, respiratory alkalosis and insulin resistance. Then patient can have some hematological and renal abnormalities. So how will we prevent that? So we, along with the feeds, we will have to give low doses of electrolytes also, like magnesium, phosphate, potassium also should be given along with the feeds. And patients will be in long-term thiamine deficiencies and multivitamin deficiency. So that also should be supplemented along with the feeds, especially in patients who is having chance of refeeding syndrome. Then when we are starting a feed to the patient, we will have to keep a very low caloric targets for a patient who was a already malnourished patient. So we will be starting with 10 kilocalories per kg per day, and we can start as 30 ml per hour. Like that, slowly we will be increasing, and as patient is able to tolerate, slowly we will be increasing, and then within 5 to 10 days only we will be planning to attain the patient's target calorie and nutrient requirements. So slowly we will be starting building up, and based on that we will be slowly giving the full diet to the patient, and along with that giving feeds, we will have to monitor for the dyselectrolytemia. So in case of fluid overload, we will have to restrict fluid. Then usually iron substitutions are not given in the first 7 days, even though patient is having iron deficiency, because that can cause a worse outcome. So even though we are starting a low feed, and even though we are giving multiple vitamins and electrolytes along with the feed, we still have to monitor the patient. So this patient will require, first 3 days will require daily monitoring of the electrolytes, especially the phosphorus, magnesium, potassium and also sodium. And after 4 to 6 days, we will be slowly transferring the patient from a low feed diet to we will be planning to reach the patient's normal expected targets. That time also we will have to continue monitoring the patient every second day. Then we will have in the remaining days, after 7 days, we will have to monitor the patient's electrolyte at least twice a week. So that was about refeeding syndrome. So we have discussed about the nutrition in ICU. how to start feeds for a patient, what are the different types of feeds, what all are the different complications, and based on patients' different conditions, what all are the caloric and protein targets which we should give the patients. Thank you.